welcome to yet another interesting topic today. So, let me start with a brief intro. So, India is entering the era of medical weight loss with new generation weight loss drugs like Wegovy, Ozempic, and Monjaro promises 15 to 20% of weight loss, making headlines. And the promise of shedding this 15 to 20% body weight is real, but so are the risks, costs, and confusion. Are we treating obesity or medicalizing the fat? As hype gets on building, India must tread carefully, and a recent public interest litigation has raised red flags about misleading advertisements and the aggressive push by pharma companies urging regulators to intervene. So, this patient centric focused webinar by ET Health World with the topic weighing in the rise of weight loss drugs in India brings high profile experts together to cut through the noise with clarity, caution, and clinical insight. So, today we have doctors from various facets who are specializing in various fields. Like we have Dr. Ashok Seth, Chairman Fortis Escorts Heart Institute, who has joined us. Thanks a lot, Dr. Seth, for joining in, taking your time. And we have Dr. Sashank Joshi, Consultant, Department of Diabetology and Endocrinology, Leelavati Hospital and Research Center. Thanks a lot, Dr. Joshi, for taking out your time and joining. And we have Dr. Mufassal Lagdawala, Director, General Surgery and Minimal Access and Surgical Science, Agent Reliance Foundation Hospital. Thanks a lot, Dr. Lagdawala. And with us, we have Mr. Vikas Dandekar, Editor, ET Pharma and ET Healthcare. So we have a heavyweight panel here, and asking to doctors to, missing their OPDs and coming for a 60-minute discussion is always challenging, and ET Health World always tries to get them so that, we get to know the facts and disseminate to the public. So let me go with the first question. So India is an estimated 254 million people living with overweight or obesity. But does that make them all potential candidates for GLP-1 drugs like Wegovy or Monjaro or otherwise? So, as India steps into this new era of medical weight loss, what, in your view, is the biggest risk we must guard against? And what is the one opportunity we absolutely cannot afford to miss? Or are we at risk of medicalizing a population wide issue without proper screening, risk stratification, or long term planning? I would like to go to Dr. Joshi first on this. Dr. Joshi.
So first of all, thank you so much, Pratibha and Vikas, and ET Health World and ET Pharma. This is a very pertinent topic, and your question is very pertinent. That obesity is to be addressed with a lot of caution and care, and we need to respect people living with obesity. So first thing is we should address them, and we should destigmatize this word. Secondly, the word fat has some stigma associated with it. As we evolved as human beings in this geography of India, we are thin fat Indians. So in our body composition, we store more fat. And it's very important that we need to evaluate a person who is living with obesity and quantify the fat. And there we don't have very good markers. We have BMI as one poor yardstick in the Indian population. Then we have waist circumference, we have waist to height ratio and many others. But we don't evaluate body fat composition in everybody. Not everybody needs a medicine. Not everybody needs surgery. The first step towards obesity, as our Honorable Prime Minister said, is to recognize that you have extra fat, and that fat can be hurtful. If it is in ectopic sites like liver and heart, it could be hurtful or harmful and deleterious. It is a mother of 200 diseases. It's a separate disease by itself, and lifestyle is supreme. So fundamentally, we have to eat less, we have to eat slowly, we have to eat on time, we have to eat mindfully, we have to do physical activity, we have to promote muscle strengthening exercises, we need to ensure that we sleep appropriately. So lifestyle is the key context. We cannot take away lifestyle from the weight loss equation. And then in carefully selected cases where there is a high compelling risk for cardiometabolic complications like heart disease, type 2 diabetes, or many others, there may be a need in people who have indications like a BMI above 30 or a BMI above 37 with comorbidities. In those cases, maybe a medical option under medical supervision may be appropriately chosen. Or sometimes if somebody is morbidly obese, for example, they have a BMI of 50, then they might see Dr. Lakdawala or a bariatric surgeon. So remember, medical options and surgical options are options for select cases, and you need to carefully filter and screen them. And lifestyle will be prevailing for all, whether you use medicine, whether you use do surgery, or whether you use the lifestyle measures. Because remember, whenever you lose weight, independent of method of weight loss, you will lose some muscle mass. Because our body is what? Body is water, it is fat, it is bone and muscle. And when we lose some fat, you will lose some muscle. It is the muscle to fat ratio which also needs preservation. So I would again reiterate that your question is very apt and appropriate, that lifestyle is the key, but we never had compelling medical weight loss options. And which is why we have all gathered here, that these compelling medical weight loss options have very robust evidence on prevention of, say, heart disease or many other compelling conditions like diabetes, etc. So that is why we have a little more enthusiasm about this entire spectrum, because up till now every weight loss so-called medication which came in the market had a dubious distinction of having some adverse event and unfortunately got banned. But now we have agents with compelling evidence in the uh, overall outcome space. So we can have better health outcomes, and people living with obesity can aim to be complication free and can aim to be more conscious of themselves and work on themselves.
But Dr. Joshi, only lifestyle change becomes a very big issue nowadays with all the gadgets and Zomato. We can just fetch in a lot of food and eat anything at any time. So lifestyle changes is one thing which is very difficult. Pop in a pill, and if you reduce, everybody is happy to do it. Let's go on with the conversation. Let me bring in Dr. Lagdawala. Over to you, Doctor. What do you think about this?
Thank you, Pratibha Vikas. Thank you for getting me on this panel. Just today there was a tweet out from the PMO that actually spoke of childhood obesity and its struggle with people being obese at the very, very young age and young onset diabetes, which Shashank would probably be far better equipped to talk about. And that's what India is dealing with. We are dealing with a pandemic of sorts of growing proportions, and we can ill afford to have that. And I think it's great that the Prime Minister himself has spoken about the fight against obesity. Now, like you said, lifestyle changes and diet and weight loss has been synonymous for years and years because people thought that was the best thing. But the problem is obesity per se as a disease is chronic and it's complex. It's got too many factors associated with it. So it's not as simple as calorie in and calorie out. Can I sleep more? Can I do that much more exercise? Can I lose that weight? If it was that simple an answer, we would not be having this panel in the first place, right? The problem is the chronicity of the disease, that it's a lifelong disease. And like Sachank correctly said, it's a harbinger of a host of other illnesses that it brings along with it. Lancet just recently, a few months back, actually declared it as a disease. The World Obesity Federations across the world had declared it as a disease long back. The American Medical Association had declared it a disease long back. And the World Health Organization understood it as a disease. But for whatever socio-political reasons, so far it's not been defined as a disease in most of the developing countries of the world. The problem is that the health uh, burden of having a growing nation, especially like one of ours, which is aiming to be amongst the developed countries of the world, will be ill afforded by us if we don't do something drastic about it. And I think that's where I believe that we should think that what is the chances of someone with a BMI of above 27.5 getting to knock off his weight with just mere lifestyle and illness. What data and what medical literature has proven is that there's 99% chance that there's going to be a yo-yo, a weight relapse, and that weight will come back on. Because all of us as humans are meant to conserve whatever little, like Shashank said, we've got the thrifty gene within us. We will conserve everything in trying to fight that weight. Once you're at a certain weight, the body will always try to pull you back. And that's where I believe that it's exciting times that we live in. With these drugs, I think the whole discussion around obesity as a disease has changed. We had bariatric surgery before, but it was meant for a very few percentage of people, and it was thought to be very radical. Surgery is always thought to be very radical. Shashank again mentioned that the drugs that we had before were not as effective or had side effects in a short period of time. So I believe that the advent of the GLP-1 analogs, or the obesity management medications that we call it, has really changed the dialogue in the space of bringing it out to public discourse like we're having this conversation today. I think these drugs are here to stay. I think that sooner we realize that we should have a combination of therapies rather than just lifestyle and exercise should be something that we should really look at as we grow obese as a nation.
Thanks a lot, Dr. Lagdawala, for your initial pointers. I think Dr. Ashok Seth is joined, but I'll just wait for another. Dr. Seth, if you can you hear us? Okay, let me go on. Sir, I would like to bring in Vikas sir. Sir, if you can start off with your questions.
Yeah, I think we can finish the loop. Dr. Seth is right there. So we are actually taking initial comments from our experts, sir. Anything that you would like to say about how you see the whole market panning, about how the patient treatment is going to change? Any thoughts from you? And then we can go to the second round. Dr. Seth, are you able to hear us?
No, not, yeah, now I am.
Okay. So was the question clear, or do you want me to repeat it again?
No, it wasn't clear at all. I had to, now I'm hearing the sound.
No problem. No problem. So, sir, we were actually trying to get some expert views on the impact that the weight loss medications are going to make on patients, how the paradigm of treatment is likely to change. Dr. Shashank Joshi mentioned to us about 200 underlying conditions that obesity leads to. It's the mother of so many diseases. Dr. Lakdawala also mentioned about the segregation of how, beyond 27 BMI, what are the options that we have. So thoughts from you, sir, about the cardiovascular implications. We know semaglutide also comes with a 20% reduction for MACE. Any thoughts from you? Yeah.
No, I think these are very important thoughts, and I think they've really given a lot of insight into especially, the most recent glucagon-like peptide inhibitors, receptor agonists. It's getting clearer and clearer. We know that in our own country, more than anywhere else, obesity is on the rise. And it's become not just a topic of information, it's become a topic of concern to the extent that even our Honorable Prime Minister raised this issue. And the facts are true. 35% of our population is either overweight or obese. And by the way, when we talk about the BMI, we're talking about different BMI figures than compared to the West, obviously. Even 25 milligram per square millimeter is a 25 kilogram per square millimeter is an important aspect of our BMIs and obesity, because we're smaller frame individuals. We have higher risk of cardiovascular disease. And there's no question that obesity, which is a lifestyle disorder at the moment, is leading to majority of the problems that we see as far as cardiovascular, peripheral vascular disease, diabetes, hypertension, and other problems are concerned, be it musculoskeletal, be it even neurological. For once, we've got a drug which clearly reduces weight and therefore is not just a fad, but in people who are overweight, and I must qualify that, for people who are overweight and fall in the BMI index, by the way, the Western study's been done over 27 BMIs, lead to reduction of cardiovascular events. There is no question around that. And I think that's very powerful. They lead to decrease, they increase for people who got peripheral vascular disease. Again, major studies got proven. SELECT trial was one of the most recent studies which was talked about where remarkable improvements were seen. And in peripheral vascular disease, 6-minute walking test. That is amazing. Nobody could ever believe that you could have peripheral vascular disease benefits in terms of claudication, in terms of walking with these drugs. So what we see, of course, is that for people who need to reduce weight because of medical reasons, and I want to specify that, because of medical reasons, it adds on a huge benefit with low incidence of serious side effects at the moment. We have certainly longer term studies, and obviously these outcome studies are always long-term. Does it mean how long a use of this drug, indefinite use of drug? We will get into that later with all our experts which are around. But I think it's getting more and more important for our own country. I would say that very clearly. Where coronary artery disease and lifestyle disorders have increased immensely, where heart attacks have grown 300% over the last 20 years, where diabetes and hypertension have increased immensely, where even our children, 25% of our school children are overweight or in the obese category, we would see, hopefully in times to come, be able to decrease, at least to an extent, the outcomes for many of our patients. And then
Sure.
I must say, we had to resort to bariatric surgery. Diabetologists, endocrinologists resorted to desperate cases of uncontrolled diabetes by bariatric surgery. I think Dr. Joshi would be one of the first ones to say that the bariatric surgery, even in his own practice for control of diabetes, is practically disappearing as a management strategy for people who are overweight and have uncontrolled diabetes or lipids or even manifest coronary artery disease. And by the way, we must also re-emphasize all this data relates to overweight individuals with high BMIs who already have existent coronary artery disease. It is not data for prevention, I must say. It's data as a treatment strategy. And it's not indefinite. And while it's being used as a drug for weight loss, as in terms of appearances and in terms of the sake of looking better in the short term, maybe that's a small proportion of its use, or an important proportion of use, because once people get on to looking better, then they are more incentivized to maintain that through lifestyle modifications. And for them, I would say this would not be a long-term drug. That would be a short-term agent to incentivize them to be able to then get to lifestyle modification. There are some who can't just lose weight and have this barrier, and they will need to make the first barrier to lose weight, and then they can get to lifestyle modification. Well, I think it's a helpful strategy in those patients, those people as well. I think I don't call them patients.
Right. A great start to a discussion that we were actually expecting to be very exciting. So for the next round, Pratibha, can I go to Dr. Shashank Joshi? Okay. So, sir, we know about the way medicines are handled in this country. We already are facing a situation of massive antimicrobial resistance. The use of antibiotics has been a major problem, and hospital infections are really growing. Uh, in a country like ours, where do you think should we be looking at dispensing these drugs, given the situation that there are no controls on regulations? Of course, there are massive, enormous benefits that all the doctors have actually encapsulated in this talk so far. What do you think should be, because there was a petition filed in Delhi High Court which mentioned that this drug is being given in gyms as magic formula, and it might lead to serious situations. Any thoughts from you, sir?
So I think I would echo the sentiments of Dr. Ashok Seth. These are medical drugs and they are strictly supervised drugs under a prescription of a medical consultant who is either a physician, endocrinologist, cardiologist, or a specialist. These are not drugs over the counter at all, number one. Number two, as Professor Seth very rightfully mentioned, that there are compelling people who need them.
Yes.
So they should not be at all deprived from that. For example, if somebody has diabetes with heart disease, with peripheral vascular disease, and many other medical comorbidities like, say, a fat in the liver called MASH, then obviously this drug will have compelling, they have obstructive sleep apnea, they are taking a CPAP machine. All these things will be resolved. And their quality of life for those people who are distressed with multiple comorbidities will be much, much better. And that is where the data stands. So I think let us be very, very clear that these are medically supervised drugs. These are not over-the-counter drugs. You need a dedicated endocrine stroke physician, stroke an expert or a medical expert who can only prescribe it. The DCG has been very clear about it, and they should not be given without a prescription. And I think that is very categorical. Both the innovators in this space, which are currently available, have also made it very clear. Also, these drugs are novel and new. They are not more than 4 or 5 years old. They will need a pharmacovigilance. We have a robust pharmacovigilance system. Unfortunately, we don't report that on board. And as I finally said, even if you take medications, you need modifications of your heart drugs with your cardiologist, of your kidney drugs or liver drugs with your expert. So these are supervised drugs. Even people like Dr. Lakdawala may be using them when they see severely comorbid morbid obesity who are not fit for surgery. If they have to get them fit for surgery, they may be pre-surgery giving these drugs, getting them to a fitness, then doing the surgery, and then following them. But these are all supervised regimens, and these are not to be given. Otherwise, they will not be. This is not for which it has been, indicated at all. And I am quite. I think for that we need to ensure that our pharmacy system, which exists in the country, becomes more robust. And we have to ensure that we follow a prescription route. So these are prescription drugs, and these are expert drugs under expert supervision. So I'm very categorical and clear about it. I don't think there is any cobweb. I think all three of us as experts here have the same sentiment, and these are compelling drugs with a lot of evidence. The data generated is huge, but we must reserve it for the most deserving people. This is not a cosmetic drug to get into your right shoes and your right outfits. No. Yes, it has some cosmetic benefits. They definitely improve your image. They improve your self-esteem. They elevate your depression. They make you a little happier. I no question asked about it. But these are not cosmetic medications. Let's be very clear. These are medically supervised drugs, predominantly from the diabetes space, with compelling outcomes in the cardiac space. And now those outcomes have gone into the liver space or in the peripheral disease space and so on and so forth. And therefore, these are the drugs of evolution, and the data generated and the number of trials both these drugs have are quite huge, and many of it is still ongoing data. So I think let's be cautious. Let's be selective in ensuring that the most deserving people get them. And that is what has happened worldwide. Worldwide, because of the use over the counter like use, the most deserving people who are suffering from vulnerable comorbidities and serious medical diseases like heart disease or liver disease or kidney disease or peripheral vascular disease have been deprived of it. And I don't think we should do that. In India, we have a large burden of that population, and we must ensure that we get these to the most deserving population who are living with obesity.
Can I just come in
Yes.
and just very briefly augment what Professor Joshi just said, but also add to that even I, as a cardiologist, who, as you know, our societies, including American College of Cardiology, recently called it the first line agent, weight reducing drugs as a first line agent for treatment of obese individuals with coronary artery disease. Despite that, when I have to prescribe this agent, I actually refer it to my endocrinology colleagues to start the prescription and supervise the management, even though I could have prescribed it. So I want to even augment and even emphasize that very fact that medical supervision, it is a drug to be prescribed by specialists with complete supervision for a purpose of secondary prevention of heart disease, as far as I'm concerned, and certainly to get rid of many other consequences of obesity, which could be morbid obesity, right from overweight to morbid obesity, which can happen in a population. And therefore, for me, even I don't prescribe it. I refer it to my colleagues like Dr. Joshi to say, take this on. This person needs this drug. It is a treatment,
Yep.
and it's a secondary prevention.
Right. Very important addition. Dr. Lakdawala, you'd like to go in next. I mean, have there been situations where you've got requests and the patient probably doesn't qualify and you say no? Any use examples that you would like to share? So you're on mute if you can unmute.
being a surgeon, especially a bariatric surgeon, you get a lot of requests quite often. And most of the times, I can say 90% of the times, we are landing up refusing surgery requests. So you can imagine the number of requests we get for the drugs. Unfortunately, these drugs are being targeted as a simple solution to not exercising or dieting. And all three of us have reiterated time and again that the basis of any weight loss management remains diet and exercise, and a healthy diet for that matter. These drugs will not work in solo. Okay, these drugs, like Dr. Seth said, are very clearly identified for that serious population. They were diabetic drugs repropositioned in higher doses for obesity management. So they are for serious diseases, they are for chronic diseases, and they should be used for that. Um, if people are using it for self-esteem and for trivial weight loss, well, I think that the side effects of these drugs will far outweigh the benefits that they seek to get, and there should be a caution label on that. And that is why I think, like what you said, it and Sashank clearly stated, these are drugs that should be prescribed by specialists in the domain who are practicing it, because then the side effects of these drugs will be monitored. They should not be prescribed by pharmacists who say, okay, this is a weight loss drug, just take it by the counter, it's over the counter available, because that zone will come in soon. Today, these drugs are being managed by two main innovators in the space. But once the generic form comes in, my fear is, and that should happen next year, that's what will happen. And that's where the antibiotic resistance you were talking about will step in along with these drugs. The same thing I fear might happen. And that's why we need some pharmacovigilance in that space, especially for the generic makers when they do come.
Pratibha, you want to go to the next round?
Yes, yes. So I would specifically want to talk about the Wegovy one, which is recently launched in India. To Dr. Said, I would want to ask about with Wegovy now approved to reduce cardiovascular events, is what they have been telling us. So, do you believe that obesity conversation is it shifting from lifestyle to mainstream cardiac care? Could this redefine, or how do we integrate obesity treatment into heart disease management in India? You've been doing it, but in the point of view of these drugs coming in, Dr. Singh.
Having put everything in the context that this is a prescribed by specialist medication, let's start understanding Wegovy is semaglutide. And we've got injections, we've got tablets of semaglutide. And we want to understand, so Wegovy is the trade name, so we just stay away from that and just talk about these drugs. So semaglutide itself, very recently, of course, has undergone not just trials in diabetic space, who are anyway high risk for coronary artery disease and so on and so forth, but we're just talking about patients without diabetes who had coronary artery disease and were therefore high risk for cardiac events and were overweight. To the extent that multiple trials are now demonstrating, and Select was one of the best. More recently, Soul CV was also presented. These are in patients who are at high risk. Each one of them demonstrating the same over a period of 2 to 3 years, demonstrating cardiovascular benefits and hard endpoints: death, MI, cerebrovascular accidents. These are hard endpoints. These are not soft endpoints of, just a bit of drop in pressures or, better control of diabetes. This is talking about what we call survival. And when this drug starts showing advantages in that, and by the way, all these are supervised, obviously, these are trials, and these include specifically, that's why I want to be so clear. These are not trials being done on anybody who has coronary artery disease, but people who are overweight, obesity, which itself is a risk factor, and therefore in large BMIs. When they show benefits, the American College of Cardiology, very recently, exactly 2 weeks ago, has come out with a clear statement around semaglutide based on the drug. And it's not just therefore an add-on drug for us. It's now become a first-line agent along with lifestyle modification. Because as you can understand, a lifestyle modification in an overweight, obese person, high BMI, greater than 27 kilogram per millimeter square, takes its own time to get down to the correct weight, and he may be very frustrated. But each time that we don't get him down, we are putting him at a continued risk of cardiovascular events. Looking specifically at those patients, for us, it's become a first-line agent to say, you're overweight, you already have blockages, you've had a heart attack, and you say you can't get your weight down, we'll help you to get your weight down. And for us, start your exercises, start your weight, and here's the drug. And I would then refer him to my colleague, endocrinologist, say, we'll put him on this drug because we want to improve his outcomes, we want to decrease his heart attacks, we want to improve his survival, till a time that we get him down to the optimal weight. The real question is, do we continue him forever? Probably not. In fact, obviously not, because we still do not know the consequences of indefinite. Perhaps they may be safe, but obviously no drug is safe, not even a paracetamol tablet. And therefore, when we look at these, we say pharmacovigilance is best done by the person who prescribes it for a purpose, which is decrease in weight. And if that is achieved, can that person, that my patient who has coronary artery disease, previous heart attack, was overweight, has he got enough lifestyle modification into him now that I can gradually withdraw this drug gradually over the next few months so that he's able to maintain that optimal body weight, which therefore has resulted in improved cholesterol levels, that has resulted in control of blood pressure, has resulted in control of diabetes, and more importantly, we may be, from there on, we will transfer him to good, healthy lifestyle, of which he's now become an integral part of. So
No.
yes, it is a first-line agent, and I want to emphasize that a first-line agent for people at high risk, but not necessarily an indefinite long-term agent.
Okay. I would also request the participants. I know you have been adding questions. Keep on adding. We would be trying to accommodate all of your questions. There are a lot of doubts in it. As Dr. Lakdawala was telling that you are getting a lot of queries, doctor, about the drugs. Even journalists, health journalists get a lot of queries on these pills. We have no idea. So that's why we thought we'll do a webinar with the experts. So push on the questions. We'll try to get it answered by our experts. Let me go to Dr. Joshi. Dr. Joshi, the side effects like nausea, gallbladder issues, vision loss, weight regain, post discontinuation are now well documented in such drugs, right? So should these drugs be considered lifelong therapies, and is that sustainable in the Indian context?
So let us put them when we don't use them. So if somebody has history of pancreatic disease or pancreatitis, we should avoid them. Somebody has gallstones or a gallbladder, lithiasis in the bile duct, they should be preferably avoided. That should be first sorted out. Then if there is a liver test and amylase lipase done, that may be a good filter. There is a rare case of multiple endocrine neoplasia. So sometimes we do a calcitonin test, which is why medical supervision is required. As Dr. Sheth was saying, that we do all these tests. We see whether these filters are cleared. And many of our people now have also been drinking a lot of alcohol. So if there is more than one or two risk factors for acute pancreatitis, one has to be cautious because this class of drugs are known to trigger pancreatic disease, stroke, gallbladder disease. Now, the adverse events are nausea, vomiting, diarrhea, constipation predominantly. Occasional adverse events beyond that can also occur. Most of them are dose limited. That is why we start slow, go slow, and gradually increase the dose. That is the second thing, which is again the reason why we need to have medical supervision. So that is the second challenge. The third thing which we need to recognize with these drugs is that these drugs need supervision, but at the same time will have very good positive impact also. For example, the epicardial fat, the liver fat, all will be chopped off. So, and they will create an endothelial medium. And sometimes these drugs are doing beyond weight loss. For example, Professor Sheth was mentioning to a trial where the separation of curves occurred much before the weight loss started. So these drugs may have, like semaglutide, etc., might have some unique, like for example, tirzepatide has 2-in-1. It has a GIP component to it. Semaglutide has an inbuilt component in its molecular architecture, which may be having a pleiotropic effect, means all-purpose effect. So I think these drugs are like the statins, which were life-saving. They have a life-saving potential. They need medical supervision. As Professor Sheth rightfully said, that if a drug works, it will have effects and side effects, and we'll need careful supervision.
Okay, thanks for that, Dr. Joshi. Vikas sir, if you can go on the cost factor with the experts.
Oh, yes, absolutely. That is another conundrum that we are trying to solve. Exactly, how do you think, I think semaglutide spoke about high dose of about 26,000 rupees. Now, if the prevalence of the disease is so huge, where do you think we should have the issue of affordability coming? Dr. Lakdawala, you would like to take it first. Do you think this is something that can be afforded by our population? Do you think it really needs to be controlled? What kind of a situation do you see emerging?
First and foremost, that the launch of Wegovy that just happened recently of the semaglutide, after their oral submission of the Rybelsus that they had initially marketed, I think they've done a good price range. I think that they've come with, like you said very clearly, their top range goes at 26,000, which is the 2.4 milligrams, 1.7 milligrams, I think is at 24,000. And the other ones that the starting ones they've done is at around 14 or 15,000, around that price range. The good thing is that majority of the patients don't really go right up to the top range, right? There are a few who go to the top range, but there'll be a majority of them who don't go. We do also understand that these are not the price line of drugs that are available, like a metformin, for example, for diabetes. And all three of us agree to that these are going to be prescribed by people seriously, physicians, consultants who are seriously in the space of diabetes or obesity management, for example. They would know when to prescribe this drug. For example, any patient who we believe is galloping towards a MASH or fatty liver disease, which can go towards fibrosis in the liver and cirrhosis, or someone with a worsening kidney status or kidney renal disease or peripheral vascular disease, and he's obese, I think then the value that these drugs will add, even at the current price point, will far outweigh the cost implications. Because if this patient develops these complications, then the amount of money he will spend on just managing all these complications will be far higher. I do believe, of course, that within time, the value of these drugs will drop, the cost of these prices of these drugs, especially next year, I do believe, when the generic drugs do come into play. But it is meant for a select few right now. Like we've clearly said, I think that price point of preventing complications will far outweigh the risk that these drugs or the price point of these drugs bring on today. So I think it's a fair call. It's much cheaper than what's available abroad. So for those who are obese and diabetic and money is not really a concern, I think this is the molecule that they should be going to when Dr. Joshi and his ilk prescribe this drug to them.
I'll go to Dr. Joshi now.
Cost, the cost of complications is far larger than the cost of treatment.
Yes.
And India is a unique geography where we want affordable access. So I personally feel that it is a scale of the use. Current cost is a barrier. It's affluent population which is tending to put on extra fat. We have actually a dual geopard in India because we still have a population which is underweight, and we also have a rapidly changing social gradient where the fat is growing very fast. We also have a urban as well as a rural, middle class, new rich class, which is rapidly putting on weight. And that is a cause of concern. The reason our Honorable Prime Minister red flagged this issue is predominantly because of that. And in that middle class, new rich class, at least this is a within a rich possibility. Of course, we always want affordable access. And but as I said, that cost of treating a chronic disease is ensuring that they are complication free. And when you are looking at from a complication standpoint, these drugs have compelling data, particularly as Professor Seth rightfully highlighted, in the cardiometabolic space or cardiovascular space, blood vessel space. They are very compelling data because we are treating end stage disease, and rather than treating end stage disease and complications, it is better to nip it in the bud, and therefore there is a price. And as I said, that there is a likelihood of its generic potential coming up very soon. So that is also a possibility. But I think currently the most deserving at least have an access to it, and at least it is in the range of a middle or upper middle class patient to at least get that option. And therefore, this is a space where it is possible to do it.
I just want to address this issue also, in addition to what my illustrious colleagues have said. We must remember that we're the world capital of heart disease, heart attacks, strokes. If you actually understand the fact that we've got half our population, which is youth, which is going to get older and therefore increase its incidence of heart disease and heart attacks numerous times over, the fact that we've increased 300% heart attacks over the last 20 years, and we've grown in obesity to a level which is 25% of our population at this stage. You're all well aware of this National Family Health Survey figures. And the fact that by 2050, half our population is going to be obese. Can you imagine the extent of heart attacks and coronary artery disease and strokes and peripheral vascular disease that we will have all across? It would be a pandemic of heart disease in our country, because obesity is on the rise, hypertension, diabetes, and now we have. So when you put this into the context of saying there's a drug available where 10% decrease in weight, we know with all our statistics that in a patient who's got heart disease, who's overweight, a 10% decrease in stroke, a 10% decrease in weight, a 15% decrease in weight causes a 20% decrease in heart attacks, strokes, death. Now, put that in the context of the thousands of people who can be saved, firstly, and the prevention of disease growing. And by the way, these statistics come from people who were already on the present statins and other drugs, which we know prevent heart attacks. So this is not in lieu of the present treatment. This was in addition to what is the best form of treatment known to prevent, as a secondary prevention, to prevent heart attacks and strokes, etc., which is statins, which is antiplatelet agents, which is lifestyle modification, which is exercise. So you just think of it. So the drugs cost continue to decrease as more and more agents in this space will get approved. But the implication on the health of our nation could be phenomenal for those at high risk. I'm not saying health of the nation as a pill for everybody to take, just like they're taking sugar and salt. But I'm just saying, as a treatment agent, under the prescription of a doctor, this could actually modify what the future that we're thinking would be a disastrous future for this country in terms of cardiovascular disease and its growth in times to come, in parallel with obesity, in parallel with hypertension, in parallel with diabetes.
Dr. Joshi, sir, thank you so much for that very elaborate view. Sir, Dr. Joshi, do you think, the kind of multiple benefits that this whole range is going to have? And Dr. Seth also mentioned about the American Society of Cardiology recommending it as a first-line agent in certain cases.
Because I was not going to interrupt you, but there was just a thought process which I think
Please,
also
sure.
Dr. Joshi had said that even in the cardiovascular studies, which are not diabetic patients, by the way, they didn't have diabetes, they just coronary artery disease and they were overweight. Even in those patients, certain additional benefits were seen, which is what Dr. Joshi said, that it's an agent perhaps. We only understood the weight loss part of it, but additional benefits are being seen, which have to be amplified in times to come. We're not saying this drug is the greatest ever produced. Maybe it will have side effects which will go down the downstream as we use it more and more, but that's pharmacovigilance, which is on at the moment. But nothing, and I would say in large studies up to 3 years and 4 years, nothing serious apart from the side effects of nausea, vomiting, stomach upsets, etc. have come up. But that's not, so can happen, and we need to be very vigilant. What else coming to this? Can you believe that in these patients, incidental diabetes happens? By the way, statins may cause incidental diabetes, which means diabetes, which didn't exist, suddenly crops up on a drug. Well, can you believe that, obviously, in the two groups which are randomized, these are large groups of 8,000, 9,000 patients in each group, 8,500 in each group. Over the next 3 years of follow-up, the incidental diabetes was lower in the patients who were on semaglutide group compared to the other group, which means that it was preventing certain aspects. In addition to that, blood pressure reductions were seen to be larger. Like I told you, in people with peripheral vascular disease, they were able to walk better and a longer distance. And you wonder, how can the drug directly, so rapidly, within a year, start affecting people's walking distance, which is more related to atherosclerosis rather than, more related to opening up arteries. So it's providing major benefits at levels which we don't understand, and perhaps science is going to be unraveling many more of its possible benefits in patients. In patients.
Sure.
Not in public.
Sure. No, I mean, the best of the breakthroughs have come through serendipity. So probably this is the biggest of those which is coming. No, I was just wanting to have a view from Dr. Shashank Joshi about the paradigm shift that we are actually seeing in modalities of treatment, in the last 10 years. Do you think this is the kind of invention that is going to be very sweeping across major health risks, health issues? I'd like to have views from all of our three experts, but starting with you, sir.
Because I think, the compelling data which all of us have been talking about is quite in chronic disease space for people living with obesity, which is a mother of more than 200 diseases. Clearly, the data is quite compelling. And this whole class of agents, unless and until there is a major puncture, which happens in the pharmacovigilance field, this is going to be outcomes driven. And today is an era of outcomes driven reimbursement. And we are looking at a complication free world. It is very difficult in the prevention space, which is predominantly lifestyle. As Pratibha rightly said, lifestyle is very easy to prescribe, very difficult to follow. These agents are not just weight loss agents. As Professor Seth alluded to, they have a lot of extra benefits, which are pleiotropic, as we call it in the medical science. So I think these have, and if you look at the global statistics now, even the food industry, even the neurology, the various other indications like Alzheimer's disease. These are some very, very interesting sciences coming out from these drugs now. And therefore, I think this is, as Charles Dickens said, that we are in best of times, but worst of times. And I think the best of times is that we have options available which are compelling. The worst of times is that there is likely to be overuse or misuse, which has to be tempered with and which has to be supervised, because these are medical prescription drugs. That's the challenge which we have. And the main thing is that these drugs, as they scale up, they are also accessible. Now we didn't have access, now we have access. And they are coming in a competitive range of pricing. And they will probably be having a more, because India is a world pharmacy, we may have a more affordable pricing. But current model also has been competitively priced. If you look at the global price and the Indian price, it has been pretty competitive. And I think these agents are clearly game changers. If you ask me, they clearly have a role beyond just the marketing part of it. I think there is a lot of science-driven innovation. It's clearly a science-driven innovation with compelling data. That's my summary on it.
It always happens like this. We have a lot of questions, we have very less time, and there's a lot of questions coming up from the audience side also. So I don't know what to do. We'll take few audience question. Maybe any one of the expert can answer them. So how Manjaro, primarily a diabetic molecule, is getting into weight loss market because of the classic side effect weight loss is it's giving out, with also clinical trials raising the issue of increase in pancreatitis and tumors in mice as dosage is increased. Is a question from Merlin. Anyone, Dr. Joshi, want to answer it?
So, see, if a drug is nausea, vomiting is a known side effect. Pharmacovigilance is the order of the day. I think they have passed through the US FDA, European FDA filters of animal studies. So these agents are clearly safe. In people who have multiple endocrine neoplasia or familial thyroid cancers, one has to be cautious about it. So these drugs, that is the only reason that these drugs need medical or endocrine supervision, because you need some amount of supervision on these drugs. But these are just not, Mounjaro has a labeled indication both for diabetes and obesity. And mainly the condition we call it is diabesity, which means there is little type 2 diabetes and obesity both. And then the weight loss and glucose both comes down with these drugs. And it's a double agent, mind you. it has 2-in-1 drug. So there is GLP-1 and GIP. On the other hand, the other agent, Ribelsis, is oral. It's oral semaglutide, which is available with us for last 3 years. It's indicated for diabetes. While the injection of Wegovy, which Professor Seth was alluding to, if you have a BMI more than 27 with one comorbidity, like a heart disease or a diabetes, then it can be given in that indication. That is how the approved label is. So basically, its approval is for weight loss with a comorbidity.
Yeah.
I think many of Dr.
I
Singh.
was just going to say that we should really now move away from calling these weight loss drugs, because what happens when we trivializing this medical agent, which is a pharmacological agent, to make people believe that it's a pill to be taken for weight loss. And weight loss, trivializes the whole issue. What we're talking about is prevention of serious disease and heart attacks and control of diabetes. We're actually talking about disease processes and a disease process modifying agent which can improve the complications or decrease the complications in a patient. And when we talk about weight loss, we trivialize it to a common public. And I think there lies the whole thing. For me, this for me is a disease-modifying agent. Once we've got a disease-modifying agent which can decrease complications for secondary prevention of the long.
So before we close it, before I give it to Vikas,
I would even ask Dr. Joshi to comment on that, because I respect him as such an expert in this field.
I fully agree that these are disease-modifying agents, and these are not just weight loss drugs. There's no need to trivialize them. They are medical agents under strict supervision, and they are definitely here to stay worldwide for the most eligible cases. Let us reserve these drugs for the most eligible cases, where we can give people, as Professor said, we can decrease mortality and decrease risk for heart disease or heart conditions or various other conditions like liver.
Okay. So before I give it to Vikas sir for closing, we will not call it weight loss drugs. We will call it disease, modifying drugs hereafter. At least ET Health World, we'll make sure we'll do that. And we had a question on pharma ads pushing this, lot in everywhere. There's a lot of ads. We are very curious about it to ask the experts. Vikas sir, over to you. You can ask that question and maybe ask all experts to wrap the session. Yeah.
Sure. Yeah. So, Dr. Lakdawala, you go first on this. Do you think these do influence minds? People are actually looking at these splash of, public messages. I wouldn't call it advertising, but, it does really cause, maybe, some people do say it's a disease mongering, but do you see these as the right moves from large organizations, or do you see these as public awareness campaigns?
Actually, because I'm very, very happy that you brought this out on the topic, because so far obesity has been stigmatized, not only by the people who suffer from the disease, but also healthcare professionals who trivialize it as a disease. They never really talk about the 200 diseases that Shang mentioned that come along with it. We've heard both Dr. Seth as well as Dr. Joshi talking actually about disease modifying drugs. Yeah, we do know that this is something serious that we are talking about. So it's about time. I'm very, very happy that whoever's done it has brought the discussion around this dreaded disease out in public space and domain. For the first time, we are talking about cancers associated with obesity. For the first time, we are talking about heart disease outcomes with obesity. For the first time, we are talking about how liver is affected with obesity, infertility with obesity, and various other diseases that are associated with obesity. So far, it was just a trivial topic. Someone's put on a little bit more weight, thoda diet kar lo, thodi exercise kar lo, and you will lose that weight. So I think it is these messages, though it might be seen as marketing messages, I think for me, they're good.
Great. So we've probably got just about a minute left. So I'll try to wrap up all the key messages that have come. So I remember the first point that I think was from Dr. Joshi. He was very categorical. These are prescription drugs. Do not even go to the point of self-medication. Dr. Lakdawala mentioned that these are not the drugs that really work solo. It requires a holistic treatment of patients. And of course, the one that really stays is that, it's a disease modifying agent. Do not call it a weight loss and trivialize the whole situation. Of course, there are multiple benefits that will come as trial data comes out. We had some very good questions, one of which was about whether it really works on fatty liver. I think trial data is still awaited, but yeah, a lot of action is due. Again, this is something that we will be treading very, very cautiously, and we'll keep coming back with the right messaging so that people do not land up with problems. We have seen such disasters happening in some of the countries in the US, of course, and also in Europe. But hopefully we'll keep coming back on the right messaging, and with help of international level doctors like Dr. Joshi, Dr. Lakdawala, Dr. Ashok Seth, I think we'll be able to send out all the appropriate messages. Thank you so much again. I think this is a great conversation, and always grateful to all of you. Thank you so much.
Thank you. Bye-bye.
Thank you. Thank you so much to all the doctors who joined.
Thank you so much. Thank you.